Good evening. Welcome to this webcast of the Methodist DeBakey Cardiovascular Journal. I'm Mike Quinones, the editor-in-chief of the journal. And the issue that we have this time is one I am extremely proud of because the topic is extremely important. And also I'm very proud for the work that everybody who contributed has done about it. The issue is on obesity and the heart. And for years now, we all have been worrying about the obesity epidemic, not only in America, but really all over the world, and its impact in health. So we all know about it. I think our audience knows it all very well. However, most of us, even physicians taking care of patients that are overweight, we have thought of primarily two bad actors. One being the food industry in a way, creating foods that are not the best for us. And the other one is the poor patient that we blame them usually for their bad choices, their poor habits. And we tend to think people are obese just simply because they eat too much, they eat the wrong kind of food, they don't exercise, and so on. But over the past decade or more, there's been a lot of new research, new insights into obesity, and each of the articles in the journal address all of these issues, and it's extremely educational, and it's an eye-opener for everybody, including ourselves as physicians, in terms of how we should look at the problem, how should we address it, how should we think of patients, and most importantly, what can we do to help patients. So I will encourage all of you to please go to the journal and read it, because tonight, even though we have a lot of experts that are joining us, we're going to be able to touch just on a few things, sort of bullet points. But if you go to the journal, you will have a more in-depth knowledge of the topic. I'm extremely indebted to the guest editor who put all this issue together, Dr. Eleonora Avenatti, sitting on my left. Seeing her, you will not believe that she just had a baby. And she was kind enough to come and join us today. I hope somebody's taking good care of the baby.
I hope so too.
So without any further delay, I put it on Eleonora's hand. She's going to guide us through the webcast tonight and present the different authors and ask relevant questions. So Eleonora, take it on.
Thank you, Dr. Quinones, and thank you everybody who's logging in to stay with us today, and thanks for all the co-authors that have kindly given up their time to be with us today. I am very, very proud and very, very thankful for this issue, and I will always be thankful to Dr. Quinones to allow us to actually delve deeper in the obesity as a disease. This issue is mostly focused on obesity and the heart, because this is the cardiovascular journal, but this was the space for us to actually kind of break some myth, debunk some myth, and try to reach the audience, both in terms of physician and potentially patients, in trying to be providing a more helpful and more scientific-based approach to the treatment of obesity. So that's what we're going to kind of overview today. We are lucky enough to have many of the co-authors and the authors for this journal's issue. And so without further ado, we're going to dive into the impact of obesity on cardiovascular diseases. This was supposed to be an overview. We're not necessarily trying to teach anybody how to treat obesity, but we want to give the tools to at least approach the patient encounter and be able to provide more solid care. So we're going to be talking with Dr. Zul Javed, who is an assistant research professor of cardiology here at Houston Methodist, about the impact of obesity on cardiovascular disease as it pertains to atherosclerotic diseases. And then Dr. Lador, who is assistant professor at the Department of Cardiology here at Houston Methodist, regarding atrial fibrillation as it relates to obesity. So Zul, I would ask you to start and take us on a tour of the impact of obesity on ASCVD.
Absolutely. Thank you so much, Dr. Avenatti. Really appreciate the opportunity to talk about our work. And once again, big shout out to you, Dr. Q, and everyone who really organized, this effort. Really, what I would say, our article really focused on two things primarily. One is the pathophysiology of obesity and cardiovascular disease, which I think a lot of it is already known in one form or the other. And then the second piece, which perhaps is really the crux of our study, is where we talked about these upstream risk factors of cardiovascular disease, and especially the upstream social determinants of health that impact the risk of ASCVD in individuals with varying levels of obesity. So I guess I can start with the first piece, which was sort of contextualizing and summarizing the evidence around the biobehavioral pathways linking obesity and cardiovascular disease. And just in a nutshell, we really talked about the impact of visceral obesity and liver fat in terms of oxidative stress, endothelial dysfunction, and long-term, cardiac, health. We also talked a little bit about the role of leptin and really leptin resistance as it relates to weight gain, and of course, again, ultimately, long-term oxidative stress, systemic inflammation, and then, of course, endothelial dysfunction. We also discussed the role of pericardial and epicardial fat in terms of long-term contractile dysfunction. As I mentioned before, I think a lot of these pathways have been discussed in one form or the other in the past. But really, the main point of our study, or really the main message, the take-home message from our study, was the second part where we talked about how it is critically important to screen, identify, and address upstream social determinants of health as risk factors or determinants of cardiovascular disease. And I think over the past, as Dr. Q pointed out before, I think over the past decade or so, there has been increasing evidence linking social determinants of health to obesity and then ultimately cardiovascular disease. What we discussed in our article was sort of twofold as it relates to SDOH and health disparities as it relates to cardiovascular disease. Number one, we based off of our prior work and then, of course, the work that others have done in this space, we proposed that both cardiologists, PCPs, as well as allied healthcare professionals. So the healthcare workforce in general, I think there's a key and critical need for holistic cardiovascular risk assessment, which is traditionally sort of limited to your traditional cardiovascular risk factors, right? So diabetes, obesity, so on and so forth. But when we talk about obesity and cardiovascular disease, I think it becomes imperatively important to screen holistically for the plethora of risk factors, the social risk factors that impact the risk of obesity, and then, of course, ultimately CVD. So to that end, we proposed a couple of things in our study. Number one was using sort of the more recent novel approaches to screen for traditional risk factors such as the AHA, LE8, or lysessential 8. I think it's we do posit that it's a nice, solid, comprehensive framework that helps clinicians assess, comprehensively assess for lifestyle, behavioral risk factors, physical activity, diet, smoking, so on and so forth. And then the second piece which we proposed, and I think that is where really the emphasis should be, is the critical need for comprehensive polysocial scoring or risk assessment. And our team has done some work in this space in terms of developing and validating polysocial risk scores that can predict ASCVD, stroke, MI, heart failure, and so on and so forth. But a lot of that work is still not integrated into clinical decision support systems, or CDSS. I think Methodist is one of the leading health systems in the country to take a leap in that direction, where now we are in a place where we have sort of on a pilot basis integrated SDOH risk scoring into mainstream clinical care using SDOH wheel and other modalities. And I think that that piece where, hopefully sometime soon we can bridge the gap between clinical risk factor screening and then SDOH screening to inform holistic care pathways for individuals with obesity, and then really managing their risk of obesity as it relates to long-term risk of ASCVD. The second piece that we proposed in our study was co-developing approaches and pathways towards health improvement. And I think some of those approaches are being used already. So some of those include SMART goal setting, self-monitoring, lifestyle prescriptions, patient education and counseling, and so on and so forth. Really targeting both diet as well as physical activity. And then the third one that we proposed was leveraging existing healthcare resources for SDOH navigation. And it's a relatively newer concept for a lot of us in the clinical sort of space, where now, based on evidence that has been generated over the past decade or decade and a half, now we know that not only the risk of obesity, but also the risk of ASCVD, over 70% of that risk is now explained by our SDOH upstream risk factors. And I think that there is increasing recognition for the need for community navigation to addressing those critical SDOH risk factors. As I mentioned before, I'm very proud to say that Houston Methodist is one of the leading health systems in the country to use, or to at least start using, the SDOH wheel to comprehensively screen patients for their social risk factors. What we propose in our study is sort of the next step, right? So once we screen, what's going to happen with those patients, right? And so I think the next step there is community partnerships, and then really partnering with established community-based agencies, community stakeholders, community champions, to navigate patients to resources that can help address their social needs. And I think the last message that we had in our study was, how can we get the word out, right? How can we disseminate the impact of obesity on ASCVD, and how can we get the word out on the perils of obesity and the risk of ASCVD? And so I think to that end, I think the conversation needs to happen both on a patient level. And I think, unfortunately, given our, the way that our health system is structured, I think it doesn't leave much for us to talk with our patients in terms of their social risk factor burden, right? But I think that that's where, as scientists and as thinkers and as policymakers, we need to come up with a coordinated plan to not only train our healthcare workforce, but also provide some additional time for our healthcare workforce to properly, comprehensively screen individuals for SDOH risk factors as part of their clinical visits, right? And then the second piece, I think, which is really key, is community, the important role, the key role of community partnerships and community engagement. I think, and this is something that our group has been doing for a while now, is community-centered and comparative effectiveness research, really in individuals with varying levels of cardiovascular risk, including individuals with obesity. And unfortunately, a lot of the times what we see is, especially in socially vulnerable, marginalized communities, racial ethnic minority, populations, there's a huge, knowledge gap in terms of, the link between diabetes and CVD outcomes, obesity and CVD, and so on and so forth. And so I think to bridge that knowledge gap, I think health systems need to refresh thinking and need to come up with sort of a revised plan in terms of how can we engage these community partners, right? How can we engage community-based organizations or CBOs? How can we partner with them and really touch and meet people where they are, right? I myself go out, into the community multiple times, during the month, screen patients, recruit them in different sort of studies. And I think, as I mentioned before, I think there's a big knowledge gap in terms of, what is the risk of, ASABD associated with obesity, diabetes, so on and so forth. And so I think to that end, what our study proposed and found was that there's a huge knowledge gap between the clinic and the community. And in order to bridge that gap and in order to improve community level knowledge and perceptions about cardiovascular disease and obesity, I think developing and sustaining those partnerships, I think it's key. And I think part and parcel of that game is community engagement and capacity building, right? We are doing that on sort of a pilot basis where we are partnering with over 10 large community-based agencies across the city. And one of the key goals for that effort is to improve knowledge and address some of those key social barriers that I referred to. So I'll stop right there, and of course, happy to take any questions.
So that work you guys are doing, I think it's very, very important, and I'm sure that many other centers across the country are getting involved too. And I just want to remind the audience, we're talking today about the heart, but obesity has incredible bad effects in other health issues, as actually one of the articles that Dr. Avenatti co-authored, osteoarthritis, sleep apnea, breast cancer, colorectal cancer, endometrial cancer, kidney cancer, ovarian cancer, pancreatic cancer. All of those have a higher risk in obese patients. So all the work that you guys are doing will benefit not just the impact in cardiovascular disease, but really the impact in health, which is so important. I want to remind the audience also that if you have any questions that you want to send to us, just text DeBakey to 37607. Eleonora?
Thank you, Dr. Javed. That was a very good summary of a very, very extensive review that you performed, and you gave so many good inputs. And I think one of the two things that I want to maybe recircle back after we hear about policies by Dr. Vijay, maybe we can put together the SDOH and the food policies and see what are the action points that we could potentially address. But the one thing that I wanted to highlight, as you already said, was how that SDOH, so social determinant of health risk factor, can actually be pulled into the clinical encounter. And the other point is that knowledge gap that you see in the community is not only for patients, it's for providers, unfortunately. There's so much lack of knowledge, especially when it comes to obesity. We don't code for obesity, we don't consider obesity as a disease, and that means that we cannot treat our patient for what is a chronic, progressive, relapsing disease, and that's huge. And so this was part of, the spirit of this special issue as well, try to spread that knowledge with evidence-based fact so we can show up better for our patients. So thank you for that, and I would then ask Dr. Adila Dor to give us an overview of the impact of obesity on another pillar of the cardiovascular disease spectrum, which is atrial fibrillation.
Hi, everyone. And thank you, Dr. Avenatti and Dr. Quinones, for this opportunity. I wrote this review together with two fellows in the cardiology department, Dr. Jonathan Na and Dr. Sita. They're not here, but they did a lot of the work, so I want to give them their credit. Our paper discussed the relationship between obesity and AFib, and this is a topic that has gained significant attention over the past few years, both because AFib become more frequent, and also obesity has more prevalent. And the intersection between the AFib and obesity is pretty clear. Our review is talking about the incidence and the mechanism and also the therapeutic strategies for obesity in AFib. So overall, AFib is the most common arrhythmia worldwide, affecting over 50 million people. We are saying about 1 in 4 people will have AFib. AFib is a situation when the upper chamber of the heart become in irregular rhythm, and that put us in a risk for stroke and a risk for heart failure and shortness of breath, dementia, and all other comorbidities. So people really suffer from AFib. And obesity is a major modifiable risk factor for AFib, and studies showing that for each unit increase in BMI, AFib risk rises by 4%. So this is a very important issue, and of course we see in our clinic here in Houston Methodist a lot of patients with obesity and AFib. The mechanism for AFib in obesity is, of course, not one reason. It's kind of complex. First, chronic inflammation, oxidative stress, atrial fibrosis create a substrate for the arrhythmia. And some of that is reversible, some of that is not. The left atrial remodeling because of high pressures in the upper chamber and autonomic dysfunction also make AFib more persistent and harder to treat. The comorbidities that come with AFib, like sleep apnea, hypertension, heart failure, and diabetes also increase the risk of AFib. So the intersection is kind of very complex. Obstructive sleep apnea is a major driver for AFib, regardless of obesity, and definitely with obesity. And that's something that we need to screen in clinics and for sleep apnea, because this is something that we can treat even if you have obesity and reduce a little bit the risk for AFib. Regarding the approach of therapy that we also discuss in the paper is also a little bit challenging. And the point that we are discussing there is, first, there is a strong evidence of the for weight loss and reducing the risk for AFib and improving the outcome for AFib treatment, including after ablation, or if you are losing weight, then the outcome will be better. Weight loss following surgical intervention has been shown to reduce both the incidence and burden of AFib, likely due to improvement in the metabolic and the inflammatory profiles. And there are papers, and we are citing them in our review, that showing that ablation outcome are improved with a more than 3-fold reduction in AFib recurrence if we do the ablation after the surgery. So the timing of the ablation or the treatment is really important. Do we need to do it only after the patient lose some weight, only after the patient is doing bariatric surgery or any other intervention, or should we do it before because the patient really suffers from AFib? So that's, of course, something that is debatable, and there is a lot of discussion in the literature. Anticoagulation therapy is also important in AFib in order to lower the risk for stroke. And while the NOAC, the Eliquis, the Xarelto are the preferred treatment for AFib for prevention, and we prefer them over warfarin. With extreme obesity, we don't really know the pharmacokinetic, and sometimes we need to do some individualized dosing strategy. So this is also important because we treat this patient as regular patient, and sometimes they can have stroke, although they are taking the blood thinner. Other points that are relevant for treatment is the medication for rhythm control. Let's say we decided to treat with antiarrhythmic medication. So some of the antiarrhythmic medication are lipophilic. So there is some changes in the metabolism. Except for sotalol, I think all of the medications has some impact on the metabolism, on the pharmacokinetic because of the fat in the body. And lastly, regarding treatment is of course the catheter ablation that has become an established treatment option for patients with symptomatic AFib. And as I mentioned before, should we do it early or not? Before the surgery, before the intervention to reduce, to lower the weight? Should we say no to obese patient unless they will lose weight, or should we do it anyway? We really have very good tools now to treat AFib with ablation, but sometimes, and we see that and it's also cited in the literature that the risk of AFib ablation is higher with obesity because the procedures are longer. If we need radiation, then we use much more radiation with much more radiation time, duration for obese patients. And there is increased rates of minor complication as bleeding or issues in the groin. And also if there is a pericardial effusion, it's become a little bit more risky to do pericardiocentesis and so on. So as I mentioned before, bariatric surgery before ablation has been shown to be associated with lower rates of AFib recurrence after the ablation. So usually when I see these patients in clinic, I try to have them lose some weight in any way before taking them to the lab and doing ablation. And also sometimes that can lower the burden of AFib by itself. So in summary, I would say that obesity is not just a risk factor for AFib, it worsens the outcome as well. These patients are more likely to develop persistent AFib, and their response to antiarrhythmic and ablation is poorer than the general population. Weight loss is one of the most effective interventions for AFib in this population. For a 5 to 10% reduction in body weight, significantly reduce AFib burden and recurrence. And obesity management should be integrated into AFib treatment plans. And this is not very organized yet in our clinics. I mean, sometimes I think that's something that we as clinicians can do better. And as I mentioned before, the anticoagulation are generally preferred, are very important part of the treatment for AFib. And we need to pay attention that some of these patients, if they are morbidly obese, are not really protected very well against stroke. That's kind of briefly about my review, if you have any more questions.
Thank you so much for that overview. I think you raised a very important point. And I guess to play devil's advocate, as you mentioned, AFib is the most common arrhythmia that we're facing. Obesity is on the rise. That means that a lot of us in primary care, in general cardiology practice, will have patients suffering from atrial fibrillation and obesity. And you raised important caveats in treating those patients. And so I guess my question is, when is the right time? What is the right patient to be referred to a specialist? Because at this point, I would send everybody to you, and then your clinic will be completely overbooked and overwhelmed. And I don't think that's a helpful use of resources. But given all the risks that you just highlighted for us, what's a good practice? What should we be looking for?
I think we need to work as a team. I think it's important for us as electrophysiologists to see these patients early, to see what we can do at that point to improve their quality of life, and to set some set points. Sometimes if the patient only lose 10% of his weight, it's significant enough in order to take him to the cath lab next step. So I do think it's important for us to see this patient early, not late. But we should see them together and then discuss GLP-1 therapy or bariatric surgery or anything that will improve the outcome. I would say if I see a patient that is morbidly obese, it's hard for me to just take him to the cath lab and do ablation, which become for us kind of a first line therapy at that point for other patients. So working together would really help.
Thank you. And the other thing I want to point out for the audience here, because I know all the co-authors here know about this, is that 5 to 10%. That's what we consider significant weight loss from a clinical perspective, because we know we have data that is an amount of weight loss that has positive impact on a whole lot of comorbidities or other health conditions. But that is not what the patient has in mind when you're thinking of a patient that has been living with obesity and needs to lose weight. Usually a patient is like, oh, I need to lose 200 pounds. It's like, I cannot help you lose 200 pounds, but I can help you manage your chronic disease to get you a point that gets you to a better place in terms of morbidity and potentially mortality. So I think that's another thing we have to keep in mind. Discuss expectation, and because our expectation and our goals might be completely different from what the patient has in mind, and we have to be clear on that, because success can be very, very different looking depending on who you talk to. But thank you, Dr. Lador, for that overview. And I would bring you back to Dr. Quinones for the second portion on how we actually can treat obesity. How do we approach the management?
Yes, and obviously the first thing that any patient needs to sit down and start changing is their lifestyle. So I believe we have some experts here to help us.
Yes, we do. We got all the help we could get, and we're lucky enough at Methodist to have a very, very specialized pool of experts. And so we brought in our clinical manager for the Center of Weight Loss and Bariatric Surgery, Ramiro Saavedra. He was kind enough to join us for writing the article. He pulled in his team, so we had inputs from exercise physiologists and mental health therapists. So please take us on a tour on what are the first step on what we call, lifestyle management, the baseline of every approach to management of the chronic disease of obesity.
Yes, thank you, Dr. Quinones and Dr. Avenatti. So a lot of the cornerstones that we talked about in the article were just related to day-to-day things that sometimes patients take for granted. Every patient tends to focus on calories, or they tend to focus on, I want to exercise. And like you were mentioning, right, they set some goals that may not be attainable and they may not see progress, which then discourages them. But I'd say some of the things that we want to address with the patient are, and then with clinicians as well, is just thinking through some of the myths that people have about, how to lose weight and obesity in general. One of them is that they think that there's one fix for it. And as we all know, there's multiple things. Treating obesity is a multifaceted approach. And one fix isn't all. It's not just medication. It's not just proper nutrition. It's not just exercise. It's a combination of all those things. And as one of our earlier speakers was mentioning, is access to those things and accurate information about those things is important. Another piece is the focus on calories and exercise, right? When we think about a healthy person and proper nutrition, it isn't just, the amount of calories, but the type of food that you're eating, the quality of that food, and whether or not you actually have access to that in your daily food supply. And so having that part of your assessment is a big piece in helping a patient succeed. And so when we take a look at proper nutrition, right, where is a patient getting most of their nutrition from, right? Are they buying fresh fruits and vegetables? Is that part of their diet? Is it only a part of their diet sometimes? Are they eating processed food, right? Which we know carries a lot of additional risk factors for obesity as well as other diseases. And then taking a look at, what does their social support look like? Are they actually able to cook at home? Or is there someone else that's preparing the food? Are they not grocery shopping? Somebody else is in charge of that. Because we may set a goal with the patient without realizing that they don't have some of the tools in the background to be able to help them achieve the goal. And I think the third big misconception about weight loss from both a provider and a patient then is that it just has to do with nutrition and exercise. One of the things we cover in the article is how important the mental piece is to that. And by that, I mean how a patient is thinking about behavior change. What are the ways that that person was raised to think about food, eating, and nutrition, and how does that play into how they make choices about food on a day-to-day basis? Was there ever a time that they were told that food was a punishment or a reward, right? And how does that look like now that they're in their adulthood and they're dealing with a chronic illness, right? We often don't emphasize, or maybe even don't talk a lot about with our patients about specifically sleep and the role of sleep in proper nutrition, the role of sleep in digestion, and how important it is for people to get enough sleep, right? And help in the weight loss process, in hormone regulation. And so those are other conversations that I think providers can have to help dispel myths with patients when they're trying to lose weight and they may not be getting or seeing results. as we look through, how can providers support a patient, when they're trying to make these decisions on how they lose weight and what that looks like for them. As we all know, weight loss is individualized, just like all care is individualized. But how do we support that, right? I think the first thing we look at is let's meet the patient where they're at. We may be ready for a patient to change, and sometimes the patient's aware that they need to change, but are they ready to change? What steps are they willing to take, and what steps they're not ready for? They're going to push back on, or we're going to make a recommendation, and they're going to come back to us in a follow-up, and they've not implemented that recommendation. And so meeting the patient where they're at is very important. So there might be a patient who says, well, I'm not really willing to change my diet, but I am willing to, control my portions. And that's a place to start. So as a medical provider, you can always discuss that with your patients, especially those that might give pushback and say, well, I'm not really ready to change. You can say, well, how about cutting down on portion sizes? How about maybe normalizing your meal pattern, setting some small goals, and then referring them out to a dietitian or someone else that's able to help with that. And above all, supporting the patient's autonomy. What does the patient really want to do and is willing to do versus what we want them to do? Because we know what we want them to do, but what's the patient willing to do? Then we kind of take a look at the conversation we were having earlier on social determinants of health and what happens when a patient doesn't have access to a dietitian. What happens when they can't afford a gym membership? What happens if they don't have access to mental health? Well, there's quite a bit of options. So there's a lot of community-based programs that are free. So locally, they're available through houses of worship, through different community organizations. Nutrition information is overflowing. But where do we find the correct nutrition information? So a lot of our own professional organizations, the Obesity Medicine Association, the American College of Lifestyle Medicine, the Academy of Nutrition Dietetics, they all have a lot of free patient-facing resources. As well as when we look at exercise, step counting is one way that we can get patients to get moving without exactly calling it exercise. Sometimes that word is intimidating because people think they have to go to a gym, and that's not always the case. People can count steps, they can find very cheap step counters, and they can try and aim for a goal of getting 7,000 to 10,000 steps, which is what the literature can recommend on movement, right? But there's a lot of community-based exercise programs that are free. And one thing we tell our patients, if you really don't have access to any of these, or say you might be limited to your home, there are a lot of reputable YouTube channels where you can go that are either hosted by a board-certified physical therapist or an exercise physiologist that can help guide a patient, and that person has a background in their field, and they have credentials and they've got education. Because as we know, there's a lot of misinformation out there on nutrition and exercise. Everybody wants to be the expert, but nobody wants to own that accountability, right? And then as far as mental health, if a patient has employment somewhere, they might have mental health benefits through their insurance or through their employer, through EAP. And through employee assistance programs, or even say if you have an employer that has a certain insurance company, that insurance company may offer free wellness visits with a dietitian, with a health coach, or even sometimes with a mental health therapist, so that a patient has access to that. Within all of our areas, there is at least one community-based resource where we can send patients that don't have the means to afford a therapist. So those are some of the things we touch on in the article, as well as giving practical advice on where to start and what those recommendations can look like.
Thank you so much for that overview. And again, we are fortunate to have your services, a whole team that works with us, with our patient to tackle the chronic obesity disease. But again, it was important for us to highlight that even in situation in which that structure and that support is not available, we still can help our patient that are dealing with a chronic disease of obesity. And as a shameless plug to the other articles that are present in the current edition of the journal, two things. One is completely focused on how to guide the conversation with a patient, how to broach the topic of obesity and weight management. And that is, exactly as you said, meeting the patient where they are. First, assess if the patient is ready to make a change. Ask permission to discuss these topics, because it might be a very sensitive topic. They might come to the encounter with a lot of prior experiences that were kind of stigmatized and full of biases, so we have to be very sensitive in this. And then, just as a general approach to the disease of obesity, the very first article in the journal deals with the pathology and the physiopathology, the neurobiology of weight and appetite regulation, just as a primer for everybody to go above and beyond the eat less, exercise more recommendation that has been kind of the trite and old saying that obviously hasn't gotten us anywhere, because we're dealing with the disease of obesity as an epidemic in 2025. But finally, we have something that we never had before. We have drugs, we have medications, we have options to treat these patients that not only kind of get us to a better weight management, they can actually impact the comorbidities and the cardiovascular comorbidities in specific, and the cardiovascular mortality that comes with the disease of obesity. So I am very grateful to Dr. Patham and her team that put together the review on the current drugs available for the treatment of obesity. And I know you have your fellow with you. I know they did a lot of hard work on this review. So give us a tour and an overview of what we can do today from a medical standpoint.
I'll start with letting Dr. Calderon lead the first part of discussion about how and when to decide which medication to start on. And then I'll talk about what we should know if we are not specialized in anti-obesity medications. So Dr. Calderon.
Thank you. So thank you, Dr. Quinones. Thank you, Dr. Avenatti, for having us here and allowing us to talk a little bit about what we have been working on with this article. And of course, thank you, Dr. Patham, for your guidance. As a fellow, we actually got to learn a lot working on this, and it was very exciting. I think that in our article we are going deep on the pharmacological options for the treatment of obesity. And we are kind of dividing first what the options based on the mechanistic division, the incretin-based therapies, the non-incretin-based therapies, and then we are looking into more the future perspectives. There are many drugs that are being developed and studied furthermore in population that are not just with the monogenic causes of obesity. So I think that in terms of future perspective, we developed that as well and talked a little bit of more of these drugs that certainly in the future years will be approved, and we will have to get to go by with these medications and offer these to our patients. In terms of the GLP-1 receptor agonist or the incretin-based therapies, we have the old ones, the monoagonists, the GLP-1 receptor agonists, semaglutide, liraglutide, tirzepatide. But then we have tirzepatide, which is the last one, and it's the dual agonist, receptor agonist, with a much better effect and the magnitude. The impact of weight loss is probably a little bit better than its partners. So in that regards, when to decide how to start, which patient is a good candidate, I think that, and I shared with Ramiro and Dr. Avenatti as well, that we have to level with the patient and engage them into accepting and our offer, and take this step with us on taking a treatment, pharmacological treatment for weight, obesity and its weight-related complications. And basically, from a more guideline perspective, we go by body mass index. That's probably our best index as of now to choose which patients are candidates for obesity management with drugs. So currently, the guidelines are recommended to start or offer medications or pharmacological treatment for patients with a body mass index above 30. But also, there's also an option for those patients who do not meet the criteria for obesity yet, but are in the overweight category. but with who are presenting with weight-related complications. And we already talked a little bit about those complications, which are going from the range of depression, anxiety, heart disease. We have heart failure, atrial fibrillation, sleep apnea, even asthma. I think that asthma we haven't paid that much attention, but even there are studies that patients who have improved in their weight, also the asthma management can also improve. Liver conditions such as the metabolic associated steatosis, and then we have problems such as prediabetes, glucose intolerance, diabetes, musculoskeletal range as well. We have patients with osteoarthritis and urinary incontinence. So patients who are in the overweight range but are manifesting any of these weight-related complications are also good candidates to start pharmacological treatment. Now, I also want to bring this up, that sometimes probably we are forgetting about BMI, the body mass index categories of obesity and overweight are not the same in all the ethnicities. So we also have to keep in mind that for certain ethnicities, and particularly South Asians population, obesity is both a BMI of more than 25. So maybe we're just taking in the traditional categories and definitions of obesity, but probably we have to look into more and pay more attention on who's the patient and be more individualist, individualize the approach. So once we have reached this leveling with the patient and we have gotten their engagement and commitment to start pharmacological treatment, when to start, we have to look at the different options. And options in terms of pharmacological treatment, we have many. But then we have the pleiotropic effects of the GLP-1 and the dual agonists, such as tirzepatide, and looking into the cardiac and the cardiometabolic benefit. So there is tirzepatide. The tirzepatide in the largest trial and the trial that got it approved, the Servant trial, at the 15 milligrams, they actually reached up to a 21% of weight loss, and which is and I share with Dr. Ladour, and Dr. Avenatti, more than 5 to 10% of weight loss is actually proven to be of cardiometabolic benefit. But even if reaching more than 15% can also has another benefit, which is the mortality, the all-cause mortality benefit. So these goals we keep in mind, and tirzepatide can actually reach those goals of 15% weight loss. But also with the pleiotropic effect, it decreases the heart failure indices as well. The Summit trial proved that there's decreased risk of hospitalization. There's decreased risk, the decrease, not the decrease, but it prevents the amount of additional medications for heart failure. So keeping in mind that who is the patient, if we are seeing a large burden of cardiometabolic diseases, tirzepatide definitely is going to be one of the best candidates for these patients. And then also, of course, we have to take into consideration patients the safety profile, side effects of the GLP-1 receptors and the dual agonists, such as nausea and vomiting, diarrhea or constipation. Those are things that we have to discuss with the patients and educate them as well, that these are side effects that are likely to happen, but they are self-limited usually. Also, in our article, we also tried to bring up some of the matters or issues that we not usually discuss, which is contraception. And having also many patients are of childbearing age, and patients who they are taking contraceptive pills or contraceptive medications. So also we try to touch on that and have that part of the discussion as well. Bring that discussion with the patient, letting them know that the pharmacokinetics of the contraceptive pills will be altered by the introduction of GLP-1 receptors, especially by the slowing of the gastric emptying. There are a couple of studies that we cited that saw that the estrogen and progesterone, actually the maximal concentration in serum can be a little bit lower after introducing GLP-1 receptor agonists. So we have to educate the patient that there is a probability of or increased risk of failure of the contraception and we have to take measures to help these patients, go by this possibility. And then there are several social determinants that are not patient-specific that may limit the use of GLP-1 receptor agonists and the dual receptors, such as sometimes insurance, finances, or even the development of side effects. So we also try to bring up and put on the spotlight non-incretin-based therapies, such as the topiramate phentermine medication. It's been in the market for a little bit longer than tirzepatide, of course, and it has its benefits. On the trials that got them approved, phentermine topiramate reached weight loss of 10%. So the caveat with phentermine topiramate is that it is an alpha agonist, so it can also increase a little bit of hyperadrenergic state. So patients with history of heart failure or with atrial fibrillation or hypertension also, it's probably a little bit, we have to be more cautious with those patients. We have to be keep in mind that hypertension, pulmonary hypertension as well, might be affected if we introduce these medications. But the weight loss of about 10% will also improve the cardiometabolic profile of these patients. So it is, I think that we have to keep this option as well in mind when GLP-1 receptor agonists are not an option for whatever reason it might be.
Thank you.
That's
in an ideal world, we would like everybody to be on the best medication possible with the least possible side effects and the most efficacy. But unfortunately, we are in a limited setting, and sometimes we have to make do. And so I really appreciate the fact that in your review, you did review the, let's call them older medication. We are kind of all looking at them like, but they are available. They are more accessible for the patient, and they do have a role in the management of obesity. I'm going to go to Dr. Patham super quickly. I really want to have the discussion about the food policies at the end of this conversation. What do you wish the non-specialists knew about anti-obesity medication?
Thank you so much for this opportunity. Just like everybody else said, set an expectation, have an honest conversation. Patients should know that after stopping the pharmacological treatment, there's risk of regaining weight. SURMOUNT-4 showed a 14% increase when tirzepatide group was switched to placebo, for example. So we all already know the side effects of nausea, vomiting, 20 to 40%, and diarrhea also. There have been questions lingering around association with cancers. Thyroid cancer has been under a microscope for a lot of time, but a new very big cohort analysis by Baxter et al. In thyroid in January 2025 shows that overall use of GLP-1 relative to DPP-4 inhibitor is not associated with increased risk of thyroid cancer. So, and one last note is in JAMA publication by Wang et al. In 2024 did show that several obesity-associated cancers, including esophageal and many others like endometrial ovarian cancer, showed decreased negative association with the use of GLP-1. So, and I'll end by saying that the biggest challenge we are facing is the insurance approval, and I'll give it back to Dr. Avenatti.
Yeah, super frustrating. And just a quick follow-up on that, because we had questions from the audience specifically regarding cancer and cancer risk with drug like Ozempic. I think a lot of confusion sometimes stems from the fact that patients at least have the impression that these drugs are new to the market, and so we don't know what the long-term effects might be. But as you well know, incretin-based treatment have been around for a long time, just on a different marketplace, because that was for diabetes, right? So these are not new. It's not like we don't know what's going to happen in 2 years. Can you comment quickly on that?
Yeah, this recent article had 1.7 million cohort that was studied, patients with type 2 diabetes and negative association with gallbladder cancer, meningiomas, pancreatic cancer, HCC, renal cell cancer, esophageal cancer, kidney cancer, colorectal, and I think multiple myeloma. So, overall, we are okay with that, and just like I said, with thyroid cancer, just counseling them, the risk of medullary thyroid cancer is more in experimental models, and the recent publication does not show any association. So, but just having that counseling, having that discussion would be important for the patients, gaining patient trust.
Thank you so much. And then finally, switching gears, we kind of had a look at how to manage obesity, what the obesity impact is on cardiovascular health, but we're going to go upstream and see what can be considered as a potential cause of obesity. And we learned about genetics, we learned about behaviors, but we thought it was important to highlight the bigger picture of food policies. And so we brought in expert in the field, and I'm very, very grateful for Dr. Chris Vijay to be joining us from Arizona. He's the medical director of the Arizona Heart Foundation and a clinical professor of medicine at the University of Phoenix, as well as his co-author, Dr. Sareen. I know she had a different meeting before us, but she was able to join, so welcome to you too. She's the medical director of Women Heart Program in Tennessee. Welcome. Please teach us about food policies. You might be muted, unfortunately.
Yeah, he doesn't. Can he hear us? Dr. Vijay, you're muted.
I'm muted. Oh, sorry.
Perfect.
Okay, thank you so much. Sorry. Thank you so much, Dr. Quinones and Dr. Eleonora Avenatti. It's such an honor to be here. Thank you, Nish, for joining us from your international meeting. I learned so much. I went through every article in this issue, and I think this is one of the best ever consortium on obesity and ASCVD, and all of the nuances that you guys have put together is phenomenal. I'm learning so much, not just from your manuscript, but also from this discussion today. So we, in the next 5-10 minutes, just Nish and I are just going to tell you about what we have done and what we did to really discuss some of the other aspects. I mean, we know that, obesity is really multifactorial. From genetics, as you said, from neurobiological, which intervenes from, the neurohormones in the brain, to gut hormones, and then you add the social determinants of health. And at the basic level, we still want to believe that it is an imbalance between calorie in and calorie out. And when you think about it that way, then what is it that we are putting in, and what is it that we are getting out of the body, utilizing it for the purpose that we need, and how are we expanding it so that we are not becoming obese? And obesity in and of itself, as you already talked about, is not as simple as the body mass index, right? If you look at me, I mean, I'm a South Asian. The body mass index for us cutoff is 23. And so it's even if at 25, it's not about the body mass index, it's about the abdominal visceral fat. We talked about all of that in your discussion. So when you think about those aspects, then we ask the question, is it the food that we eat? And should food be medicine? So those are the things that we're discussing in our manuscript. So what I will talk about is just the framework that we've actually incorporated, and how at the clinical encounter it should be really be implemented. And then I'll have Nish talk about the gender differences, and then also if she will address the need for policy change a lot more than the need from a new drug discovery and development. And then I'll come back and then talk about the preclinical aspect of obesity, and can we do something about it? So where are we from the framework perspective? Clearly, we have to start from the seed, from the seed to the field, to the fork, to the landfill. And that's what we have talked about in our manuscript. We're talking about the seed, where truly it is natural manure versus it is artificial, where we know where it all started from World War II with ammonium nitrate being in abundance because now there are no bombs needed. And now they put all over in industries to manufacture fertilizers. And these are not the right kind of fertilizers we need. Now they're getting into the food, and all the pesticides and herbicides are getting into the food. So now we're talking about the farm bill that was created. And the farm bill is about subsidizing all of these negatives and subsidizing high fructose sugar syrup, which is what is included in everything that you eat. Everything that you buy from the store has got high fructose corn syrup. So that is subsidized. I mean, think about it. My goodness, we're subsidizing poison. And so there is a very, very powerful need for a policy change at the seed level and at the field level. Now, what about fork level? The fork level is where we have to start thinking about the personal discipline, the personal empowerment. We are all getting succumbed to false advertising and the sweetened sugar beverage. Oh my goodness. That is what is there present in every school, every community out there. And then the ultra processed food that we're talking about, which are all non-nutritious, right? And then after that, we got to talk about the landfill. And the landfill is about the food wastage and all the greenhouse gas production that is really coming out there. And so when you look at all of these 4 different framework concepts, how do I, as a clinician, how do you as a clinician, put it across to the patient who is in front of you, who has a problem with obesity? We need to say, we have a responsibility to educate our patients. We have a responsibility to motivate them. We have a responsibility to empower them. And then they have a responsibility to take all of this messaging to go back and talk about advocacy, to talk about policy change, to talk about social safety net, to talk about all of the things that we're doing from school education. You talk about something as simple as food label. What is it that they're doing in food label? My goodness, they're telling you about percent daily value. Does any of you here, even in the faculty, know what a percent daily value is? I mean, are we fooling ourselves? I mean, this is ridiculous, right? And then they're talking about the percent daily value, and then they also, talk about they don't talk about the salt content. They talk about the sodium content, and then and then the sugar is not even mentioned, and then they confuse you. Food label is confusing for me. It's confusing for everybody. So it's got to be starting something as simple as food label. And then we got to go all the way to what we talk about in our manuscript from, to education, school empowerment, tax credit, and then taxing the non-nutritious food, the sugar-sweetened beverage at a much higher level. So as to say, and then the nutritious food, the high quality that we talk about, food security, food quality. We talk about all of that, ad nauseum, and yet we're not doing anything about it. I was in Athens, Greece, not too long ago, and it was such a phenomenal thing for me to say, for €1, I got a kilo of cherries in the streets in Plaka in Athens. And I was like, crying with joy. And I said, my God, this is the kind of thing we need to do. And a small little orange juice is €5 because it is so deeply concentrated, filled with sugar. And rightly so. And whereas over here, all of the non-nutritious is very cheap. I can get a double cheese Whopper hamburger for 99 cents. And then if fruits and vegetables are expensive. So what is it that we're doing wrong? I mean, there is something from a policy perspective that needs to change drastically. So I'm going to have Nish talk about the gender differences and then tell us about the food policy versus, should we do we need more drugs? And then I'll come back to the preclinical primordial prevention that we need to be addressing rather than primary or secondary prevention. We are reacting to ASCVD, we are reacting to obesity, we are reacting to hypertension. That shouldn't be the case. We should be preventing the onset of obesity, the onset of hypertension, onset of the primordial. Nish, take it away from here.
Thank you, Chris. Oh my goodness, what an amazing synopsis of the entire manuscript. Every time I listen to Chris, I learn something new. But very excited about this paper. And when we talk about gender disparity, just to keep it very brief, is that there are 2 aspects when we talk about the practicality of gender disparity. One is females versus men? How does adiposity vary in the two? And how does that impact their life, prognosis, and outcomes? And the second part is, what role can women play in preventing obesity overall in the real world? So if we talk about a socioeconomic level, we have described in our paper that lower socioeconomic status, particularly in female gender, is associated with higher prevalence of obesity. We do know that the downstream outcome of obesity is diabetes, hypertension, coronary artery disease, and we've talked about it. And there are definite genetic differences. There are definite gender differences between the two when it pertains to all these. We know that diabetes in women, when it is an outcome, it can cause 6 times more complication compared to a male counterpart, where the complications are only 2 times or 3 times. We do know that visceral adiposity, which is worse, is more common in women, as Chris alluded to BMI, but also waist circumference and neck circumference have evolved as ways to look at the, can we quantify fat? And particularly, and using all of these together can typically help. Preventive strategies, whether it's diet, exercising, gender-wise, is more likely to impact outcomes in women compared to men. The second important aspect in females is that health, when it comes to adiposity, or obesity, starts in the kitchen, and a female is in charge of the kitchen in most households. So it's really important to have them on the same page, and their awareness education is really important in what's coming to the table at home. Because if a child develops obesity, they're 5 times more likely to be obese as an adult. So it has to also start really early in our lives, and we should not be talking about this when patients are adults already. And targeting weight gain and prevention in young patients is the key to improved cardiovascular outcomes. I'll briefly touch upon drug development versus preventive, and I think we all know that development of drugs is extremely expensive. And when they come out, as we already talked, there are side effects, and we do more trials to learn about, do those side effects work? Are those side effects real or not? What's the magnitude of impact? Of course, if we do prevention is cheap. It's very difficult to appreciate it because the event never happened, but the impact is significant. The big question, which our paper also elaborates, is that we have multiple policies that have been launched at federal level, at state level, at regional level, but do they work? And they have really not worked. It's really important that policies that are implemented take into consideration the root cause carefully, like Dr. Vijay alluded to, and address them aggressively. And what we feel is doing it, considering the cultural impact, the racial diversity, at regional level is more likely to be impactful compared to doing something strictly at the federal level. I'll let you take over, Chris, for your part.
No, this is fantastic. Thank you so much, Nish, for that comprehensive way that you put it together. So, yeah, from a preclinical standpoint, can we prevent the onset of obesity? Should we talk about it from a clinical perspective? Low HDL, high triglyceride, high waist circumference, high waist to hip ratio, blood sugar is mildly high, A1C is high. Then we say, okay, lifestyle modification, DPP, diabetes prevention project, maybe metformin, low carb diet. You get moderate protein, healthy fat, healthy carb, add fruits and nuts, exercise, get calorie in, calorie out. What is the impact for all of this? About 2 to 4%. And that's about it. And it's not too bad, but if I'm to 300 pounds, 2% is nothing, right? So I need to really come down to a significant level. So many of these drugs have come to market. But if only we did it at the grassroots. And that grassroots I'm talking about is policy change. Can we prevent even just the onset of obesity in and of itself? Right from food labeling to community education to patient empowerment, of course, and then avoiding the sugar sweetened beverages. Can we put a big tax on all of that? Can we put a big tax on processed food? And can we then talk about you talk about what is called the farm and the food desert, and we talk about food swamps. And there are places where there are food deserts. They don't even have the right kind of, they have to travel 10 miles. The Native American community here, right in Arizona, they have to travel 10 miles to get to a grocery store to get fruits and vegetables. Now, how cruel is that? 10 miles. So we got to talk about transportation. We make it available for them to actually get the right kind of quality food. And then we talk about food swarm, which is a lot of these food is available, and then you take 10 steps and you have a McDonald's or a Wendy's or a Jack in the Box, and that's all that is available in the food swamp area. So and then we got all of this marketing, which is really targeted to the kids and to the SNAP recipients and to the WIC recipient. That they're marketing and targeting. If you think about something as simple as Coca-Cola, did you know that 33% of their revenue, their billions of dollars, is coming purely from SNAP recipients because they are imbibing a lot of this sugar-sweetened beverages? So we need a big policy change, child tax credit to avoid food insecurity, school curriculum. There is a city in Philadelphia, there is a school where they call it etiquette, where they're actually teaching them cooking skills in school. And they're teaching them how to avoid food waste. They're teaching them, so many different things. Food is medicine concept is here. It's paying for, medically tailored meals, medically tailored groceries. But long ways to go, miles to go before I sleep is one of the poems in this in Robert Frost, and truly the miles to go before I sleep is about the policy change that we need to be implementing. Policy change that will involve education, policy change, that will involve nitrogen tax, that will involve composting, that will involve fruits and vegetables to be at the lowest cost, the right farm bill, build local regional capacity building, stakeholder engagement, citizen activities, and then all of the community support. You educate your patients to start their own gardens, their own herb, their own community garden, their own hydroponics, regenerative farming. If you just put regenerative farming in YouTube, you'll get about 100 hits. And go ahead and watch some of those 30 to 45-minute program. It is an eye-opener, I'm telling you. It is here. The GMO is here, and GMOs are doing harm. A lot of the pesticides are doing harm. We cry uncle, we cry. When I came to Arizona 1990, we had one cancer center. And now 35 years later, we have 21 cancer centers. Do the oncologists know something? Or did they predict that all of this is going to happen? My God, where is this coming from? It's the air, it's the water, it's the food. There isn't anything else that we do on a regular basis every day. So we got to be talking about changing the way that we do things that gets into your own body, being cleansed from head to the toe. How do we incorporate and motivate all of this to the patient? And then how do we incorporate and motivate it to the congressmen, to the legislators? They all have their own, biases. And so this is somehow, this is our body, this is our life. We ought to be the advocate for food is medicine concept to the obesity pandemic that is not only here, it is devastating, and it is contributing to all of these comorbid conditions in unbeknownst to mankind. So I'll leave here with that thought for all of us together to make a bigger impact on our lives and every life that you touch around you. Again, thank you for having us, Eleonora and Dr. Quinones. This is such an honor and a privilege to be here and to meet many of you here. Hopefully we'll continue our discussion with the DeBakey's Journal, which is one of the most amazing, popular journals, high impact factor in the world, and indeed, so blessed. Thank you.
Thank you so much. I think we've come full circle. We started with the social determinants of health and somehow, wiggled our way back to that and to the bigger picture of policies. But in the meantime, we did look at what clinician we can do on a clinical encounter. And I just want to remind the audience that the journal also covers the other possible approaches to the treatment of obesity, which are the bariatric surgical approaches and the new GI endoscopic techniques. And again, this is supposed to be a primer for you to be knowledgeable about what options there are for your patients so you can have an informed conversation with them. Dr. Quinones, thank you again for the chance of working with you on this issue. It was an amazing journey.
Well, and thank you for doing it. And I want to let the audience know that in the history of this webcast that we've been doing for the journal, this is the very first time we go beyond the 1 hour limit, and this because this topic was so important. In fact, if it were up to me, we would stay here another 20 minutes. But I think it's time that we let our audience go. And again, we thank all of you so much for the contribution that you have made. Good night.
Good night. Thank you.
Thank you.
Good night.
Thank you.
Good night, all. Bye-bye.